Okay, hello everyone. There we go. So, all right, I'm well aware that we're the last talk before the break. We'll try and keep it relatively brief and relatively interesting. So my name is Pranav. I am a consultant psychiatrist with the PCMHT, and I will be talking to you about psychosis and hallucinations. I'll be followed by my colleague Sally, who will introduce herself. So, what are we going to talk about? So first of all, just to keep it really simple, really basic, let's just be clear on what we mean by hallucinations. We mean experiences involving the apparent perception of something that's not present. So essentially, a sense organ has been stimulated, but there is no stimulus. So if somebody describes misinterpreting something or something like that, that's not a hallucination. There is absolutely nothing causing the stimulation. We'll have a look at a few numbers. Does anybody know how common hallucinations are in the general public? The lifetime prevalence? No, of course not. Why would you know? Anyone want to hazard a guess, unless it pops up? No? Anyone want to hazard a guess? I'm going to need something louder, sorry. 20%, so that's what, 5%. You've been... So you're right, it's 1 in 20, which is 5%. So that's the lifetime prevalence. That's quite high, right? So 1 in 20 people at some point in their life will experience a hallucination. Now, most people actually think that I say most people actually think, scientists, academics feel that it may be actually higher. So let's do a little experiment in the room. There's billions of you in here. It feels like billions of you in here. So can you pop your hand up if you've ever had this experience? You felt your phone vibrate in your pocket, and when you've gone in your pocket, there's no phone. Put your hand up. Yeah, that's over 20%, right? It's not scientific, but actually some academics suggest it's up to 20%. It's over 1 in 20, isn't it? So some people suggest it's upwards of 30% of people will experience hallucinations at some point in their life. And if we look at the numbers, so something like schizophrenia, that's 1 in 100. The lifetime prevalence of drug-induced psychosis, 1 in 200. Hello? Did that change? There we go. 1 in 300, so that is schizoaffective. No, it's not. That is the other one. I can't remember. And then 1 in 1,000 was schizoaffective. Depression with psychosis, that was the 1 in 300. We'll get there. So when you look at it and you break it down, 1 in 20, that's 5 in 100, 5%. The research suggests that around 3 of those, so 60% of people who suffer with hallucinations will do so because of a mental health problem, but that leaves a large proportion of people suffering hallucinations for some reason other than mental health. Okay? So, if we look at the psychiatric causes of hallucinations, I mean, it's fairly self-explanatory, I think. Psychotic illnesses, it's not an exhaustive list, but schizophrenia, unspecified non-organic psychosis, that is the diagnosis of choice for early intervention in psychosis teams across the country. Schizoaffective disorder, but there's obviously loads more. Oh, I'm louder. Okay. Non-psychotic illnesses, things like mood disorders, so bipolar affective disorder, depression, personality disorders, PTSD. Again, not an exhaustive list. So, Tom wanted me to give this talk, I think partly to answer this question. How can you tell the difference from someone in front of you when they're telling you that they have hallucinations? How can you tell whether it's schizophrenia or a personality disorder or any of the other things? So I thought I'd have a look. And can you tell the difference from the description of hallucinations alone? No. Sorry. And we'll finish there. No. So the Schizophrenia Bulletin did a systematic review of I think it was something like 78 papers or something like that. And they concluded that from our systematic review, it demonstrates that almost all phenomenological, clinical, and epidemiological features of hallucinations in schizophrenia are also represented in other population groups. And that was both non-clinical and clinical population groups. Our findings did not support the notion that some features of hallucinations are uniquely diagnostic of schizophrenia. So when you look into old textbooks or you think back to medical school and you're told about asking about, you know, are the voices inside your head or outside your head? Are they talking to you, about you, around you? Realistically, first of all, it's very hard for patients to know what you're talking about. But realistically, it doesn't make a difference. It's very difficult, just from the hallucinations themselves, to be able to differentiate the mental health condition. And that's why knowing the context and everything else that's going on in the other symptoms is really, really important. So, non-psychiatric causes of hallucinations, important to know about, because as we established earlier, that's about 40% of people who have suffered with or will suffer with hallucinations. Hallucinations can be normal, and that can be reassuring for patients to explain that actually this might feel weird, this might be scary, but actually it's normal. So grief, bereavement, especially within the first year, many people describe being able to see or hear their loved ones that have passed away. Hypnagogic and hypnopompic hallucinations. So hypnagogic is when people are in that stage where they're going to sleep. They may experience hallucinations. Hypnopompic is when people are in that stage of waking up and they may experience hallucinations. But also people can just have isolated phenomena, and it might be quite scary, but it's just an isolated incident. It doesn't happen again. There may or may not be an explanation for it. I haven't added this here, but things like adolescence as well, that can cause, or not can cause, but you can get an increased incidence of hallucinations in adolescence. Hello? Anyone know who that is? No, of course not. Sensory deprivation and loss, so sensory neural hearing loss can increase the risk of auditory hallucinations. Charles Bonnet, of course, you all knew that. Charles Bonnet, or Bonnet, I don't know where he's from. Visual loss or visual impairment can cause visual hallucinations. Phantom limb syndrome, so people who've had amputations but can still feel the limb. Drug and alcohol, and any of the stages of drug and alcohol use, so acute intoxication, chronic dependence, and acute withdrawal can all cause hallucinations. Delirium, and obviously these are the causes, or some of the causes of delirium, definitely worth considering in older and more frail age groups. Sleep deprivation, I don't know if anyone remembers that Channel 4 program, I think back in 2004 or something, where they put a bunch of people in the Big Brother house and just told them they couldn't sleep for 7 days. And then they had to abandon it because people were starting to hallucinate and really struggling. Sleep deprivation. Iatrogenic causes, so this is stuff that we do to people. We give them steroids, anti-Parkinsonian drugs, opioids, anticholinergic medications. So just stuff to be aware of. Neurodegenerative conditions, so Alzheimer's, Lewy body dementia, vascular dementia, Huntington's, Parkinson's. So again, if people are older and they're presenting with hallucinations, it's just something to have in mind. But also younger people, we've had a few younger people come through, and actually it's been early onset dementia that they've been suffering from. Neurological, I'm glad the neurologist has gone. Yep. So neurological conditions just to be aware of. Epilepsy, I think typically we hear about temporal lobe epilepsy, but it's not just temporal lobe epilepsy that can cause hallucinations. Space-occupying lesions, strokes, head injuries, always worth considering. And then other medical conditions, again, it's not an exhaustive list, but things like thyrotoxicosis or hypothyroidism, HIV, AIDS, neurosyphilis. Just things to be considering. So, when to suspect non-psychiatric causes? So this is where we might be able to tease out and differentiate. It's difficult to differentiate what psychiatric condition is going on, but it might be a bit more easier to work out if it is psychiatric or not. So age of onset. So as I said, younger people, so people going through adolescence, it can be a normal phenomenon. Older and more frail people might be worth considering things like neurodegenerative conditions. Visual, olfactory, or tactile hallucinations in the absence of auditory hallucinations. So if there was a Venn diagram, and I should have done a Venn diagram, shouldn't I? But if there was a Venn diagram and it was just visual or just olfactory or just tactile, I'd be far more concerned about a physical health cause, potentially a neurological cause within that part of the brain as opposed to a psychiatric cause. But that's not to say that people with psychiatric conditions don't also get visual, olfactory, or tactile hallucinations. It's just very rare that they are in isolation. Happy? Good. Neurological symptoms, obviously, so if people are having seizures or if they're getting hallucinations in that pre-ictal aura type phase, if there are other neurological symptoms that are going along with it, worth thinking about neurological causes. Other physical health symptoms, so obviously signs and symptoms of delirium, thyroid disease, etc., etc. Signs of infection, any recent medication changes. It might be worth just having a look, seeing if any of them could be contributing or causing the hallucinations, and then memory loss. And if memory loss is very stark, it might be worth considering neurodegenerative conditions. Cool. So, take-home messages from me. I'm going to try and keep that relatively simple as well. Hallucinations are very, very common, probably more common than is reported, as we have all demonstrated here today. Hallucinations can be normal. So I think that's an important message that I often have to tell patients, is actually this can be normal. This isn't always indicative of something really serious or of serious pathology. Sometimes these things just happen. You cannot differentiate psychiatric conditions by the nature of hallucinations alone, so it is important to understand the context and the other symptoms that are occurring to try and work out what the diagnosis may be. And considering the other causes of hallucinations is vital for expedient care. And what I mean by that is that obviously if someone is referred to me, it's a neurological cause or it's thyrotoxicosis or something else, they're not going to get the care that they need as quickly as they could have done. So please consider other causes. Thank you.
So my name's Sally and I'm the lead pharmacist for the primary and community mental health team, and I work alongside Pranav in that team, and my specific network is PKEDGE. So I'm going to talk a little bit about the pharmacy service and how it runs across the city, how you can make referrals into the pharmacy service for questions around mental health medications, and I'm going to talk a little bit about doing antipsychotic reviews within the primary care setting. We know for patients with SMI that often discharged, and a lot of those are just under the GP, and that's where the reviews are happening as well. So that's just a little bit of a flow chart which kind of highlights how referrals come into our service. So they will come in from the primary and community mental health team, MDT. So we've got we're lucky to have quite a vast MDT that we work with, so mental health practitioners, we've got the psychology service, occupational therapists, mental health wellbeing practitioners, and we work really closely with the voluntary sector organisation as well. We do accept referrals in directly from GP practices and clinicians working in from GP practices where there are specific questions and support that we can offer and advice around mental health medications. So that may be around particular adverse effects or side effects, it may be around prescribing with comorbidities, or it might be thinking about bringing somebody off medication and reducing medication. And we will also have some referrals through from Sheffield Health and Social Care, maybe via the huddle, so they're preventing patients sort of bouncing around and they can come to us that way as well. So all pharmacists are kind of allocated various PCNs, so 4 to 5 PCNs per kind of whole-time equivalent pharmacist. We will screen those referrals and we will either book the patient in for a review or we will write some advice back, so that may be back to primary care or it may be back to the referrer. We will continue to see them until they're stabilised and then we will hand back to primary care at that point as well. So hopefully that kind of outlines everything. So yes, part of our role, so we work really closely with the MDT. We know for mental health conditions, medications alone often aren't going to be the whole answer or potentially the answer at all. So we work really closely with our colleagues, and that will hopefully be highlighted in some of the case studies later. And some of our really best success stories are where we've worked in conjunction. So it may be that we're supporting with patients with medication to increase stabilisation before they do some further psychological work, or we also see patients at the other end of that where they've developed those tools and skills to manage their mental health, and we're thinking about getting them off medication, and we do attend our MDTs as well. So we provide patient education, and it's all about the shared decision making. So building rapport with the patient and building those relationships, I think that's probably one of the most important things. And we work with a trauma-based approach as well. So we're thinking about someone's past experiences that they've had before they kind of come to see us. And that may be around the medication, but it's taking time to listen to those concerns and the experiences that they've had. Some patients have been hospitalised, they may have had medication injected and forced upon them, and they've got their own ideas, concerns and beliefs. That may be religious beliefs, it may be to do with their family, it may be other people who they're close to, their opinions or their experiences on these medications as well. So it's gathering as much of that information as possible, so we're kind of working on the same page. We will initiate stop, swap medications as appropriate with the patients based on any physical health concerns, their overall functioning, and of course what their preferences are as well. And we will review and advise on patients who are coming out of area or from overseas who might be on quite complex medications that are turning up in primary care with a whole list of things. We've seen people before on 3 or 4 antipsychotics, so it's working kind of with primary care as well to help resolve that, so we're prescribing appropriately and in a timely manner for the patient. We will ask that just gather as much information as you can before you're sending those referrals over. So if there's psychiatric reports from their medical records from overseas, and we've got some documentation of what they're on, that makes it much easier for us and to kind of manage the patient, like I said, in quite a timely way. We will produce medication management plans, so that will include, we'll write that with the patient, send it to the patient as well. So it will include kind of any initial plans, but also on discharge it might include future plans for PRM medication, for how long somebody needs to be on medication for, when we're planning on maybe stopping and reducing, or next step options if those medications are ineffective as well. So just some of the criteria. So they do need to meet the criteria for the PCMH, so be able to engage with our service, not require an urgent appointment, and somebody who's requiring specialist mental health advice, who can be supported in the primary care setting. They don't have to have an official diagnosis, but either a working diagnosis or a formulation of sort of their current mental health difficulties. So some exclusion criteria, we aren't able to provide crisis or urgent appointments that would have to go through the crisis service. Anybody awaiting a mental health diagnosis, for example, wanting to start a mood stabiliser in somebody who's waiting a bipolar diagnosis, they would need to have that diagnosis first. Hypnotic and benzo prescribing, it probably links back to that we're not a crisis and an urgent service, so that prescribing wouldn't come through us. ADHD and dementia prescribing would be in specialist services, and any complexity kind of requiring secondary care. So you can, refer to us. So professionals within the service will refer to us, and from primary care, you can refer into our admin team. So an outline of why you're referring, why you think a medication review might be helpful, and what kind of things we're targeting with the patient as well. So we'll either reply back with information, we might reply back to ask for more information from you, or we'll possibly book them in for medication review if we feel like we need to get more information from the patient as well. So we work on 2 weeks to respond to queries and 4 weeks to book somebody in for a review. So far we are keeping to those numbers, which is really important that we do keep to them, because the longer those wait lists get, once it's coming into 3-4 months, we find that you'll be sending in queries and things have already changed or moved on by the time we get back, and we're not working very efficiently. So a little bit about antipsychotic reviews and monitoring. So why we use antipsychotics, I think Pranav has touched on a lot of it in his presentation. So we're talking about symptom control. So that may be patients with a non-organic psychosis. It may be patients with a bipolar diagnosis, psychotic depression. But we also sometimes see prescribing in things like PTSD, where there's psychotic symptoms present, or in personality disorder, although the evidence in personality disorder is really poor for medium to long term use, but we will sometimes see that anyway. We're thinking about reducing levels of anxiety and distress, as well as reducing that symptom management. We know that for patients with psychosis, it's about reducing the distress and the anxiety around the symptoms that they may be experiencing, which may be hallucinations and other symptoms as well. And we know the evidence tells us there's a reduction in relapse rate. So if somebody continues to take medication after having a psychotic episode, they are less likely to relapse than somebody who stops medication. So we're using the evidence base. As with a lot of medications, we don't have long-term studies. The studies are all short, maybe kind of 2 years. There were some studies that came out of Scandinavia, which were a little bit longer, kind of up to 7 years, which really support reducing doses of antipsychotics in the longer term for better overall functioning. But there's more studies still needed. So what can we do in primary care? So we know that we have our health coaches who are coming into practice, hopefully supporting you, doing the physical health reviews, and the numbers have come up massively in recent years. We do also know that for patients with an SMI, they tend to die 15 to 20 years younger. And some of that is linked to the medications that we are prescribing, and some of it is linked to kind of other lifestyle factors as well. But it's thinking about what we can do in terms of reviewing those antipsychotics on top of doing the physical health reviews as well. So a comprehensive review, so include side effects, the standardised rating scales. You can get the gas on your system one. You can add it to your tree. That gives us a really good idea of what side effects someone's getting, and also if we're making changes, we've got something there to kind of compare against as well. So how effective is it? But also, how is someone functioning? So they may have a reduction in the symptoms, but how are they functioning overall? Is the sedation that it's causing preventing them from being able to go to work, causing issues in relationships, preventing them from doing kind of other things that they may enjoy as well? Thinking again about their own attitudes, beliefs around medications and their beliefs. They may or may not be taking the medication, and I guess that's one of the first things to ask. But do they really believe that they need it, and that's what they think? Is it something that they would like to come off in the long term as well? So we're looking at that, and then those are the physical health parameters. Hopefully you're all familiar with them, and they will form part of the SMI review as well. So it's doing those annual bloods on top of things like weight, BMI, the cardiovascular, blood pressure, pulse, because we know that antipsychotics are affecting all of these things, and particularly the second generation with the metabolic side effects. Yeah, so this is the gas. There's Lunzas as well, but this one kind of is the one that I would prefer to use. And sometimes if we ask somebody, are you having any side effects of your medication, they say no, and we can go through this and actually identify that they may be having quite significant side effects that they're affecting their functioning. So it's helpful to kind of have that on the record and to repeat it at least annually, but after medication changes as well. So what can we do about the side effects? We can offer some practical advice. So that may be advice around weight management. It may be advice around dry mouth, using artificial salivas, things like that. But in terms of the medication, I guess there's three main things we can do. We can reduce the medication. A lot of these side effects are dose related. We can think about changing something else that is less likely to cause that side effect, or we can add more medication in. I guess the last one is not always my preference, but adding medication in to more medication that's got its own side effects, and it can kind of end up in a bit of a cycle. So it's perhaps looking at the other options first. Some factors to consider when stopping. So it's always a shared decision with the patient and taking into account what they want to do, unless they had some really serious physical effect and they had to come off that medication. So again, it's building that relationship. What are their thoughts, ideas, concerns, and listening to that. Are they symptom-free, and for how long? And also, what was the pattern of the illness? Do they have a care plan, so a staying well plan? Are they able to recognise early warning signs? What's their support structure like? And how stable are things for them at the moment? Have they got something hugely stressful coming up? Or are their social circumstances and support relatively good? And plan for monitoring symptoms and doing a relapse prevention plan with them. So often they'll be able to recognise their own early warning signs, or those around them can. So some common adverse effects, which I'm sure you come across. So sedation, weight gain, sexual side effects. We've got the movement side effects, metabolic syndrome, effects on the heart and QT prolongation. But also we have things like brain fog, kind of flattening of mood, those kind of symptoms as well, which are really important to patients and we don't always pick up on as easily. Weight gain is probably one of our biggest referrals, so patients having weight gain on antipsychotics, and we know it can be huge and it happens really quickly. So in the first 6 weeks, that's when we can see massive amounts of weight gain. And there's loads of things that are causing that. It's causing patients to feel sedated, dry mouth, increasing appetite, as well as kind of, if you're able to resist eating more, there's metabolic changes as well, poor sleep. So lots of things that are causing that weight gain. It causes distress to patients and affects their confidence, and that's going back to thinking about overall functioning. And it's also, when we think about that, 15 to 20 years younger as well, it's increasing cardiovascular risk, increasing risk of diabetes, heart attacks, strokes, all of those kind of things. So we know that different antipsychotics are more and less likely to cause weight gain. Clozapine and olanzapine, definitely the most prolific. Aripiprazole and lurasidone, which is red listed and we don't tend to use in Sheffield, have the lowest risk, and the others are kind of somewhere in the middle. I'm going to skip on to the second one. But yeah, so I have a couple of just patient journeys that I've seen in my clinic as well. So this was a lady with depression and psychosis who was referred because she wanted to come off medication. She'd completed some ACT therapy with one of our clinical associate psychologists. This was her second episode of psychosis with depression, but with there was quite a big gap in between, sort of about 20-25 years in between. She was currently stable. She really wanted to come off the medication. Her past experience was that she'd been able to come off this medication previously. Since admission, which was about 1.5 years ago, lots of things had changed in her life. So she was in a stable relationship, financial stresses had reduced, and she was in a stable job as well. So she wanted to come off all medication. She didn't want to be reliant on it. It was causing some side effects, some weight gain, some sedation. They weren't having massive effects on her functioning, but yeah, she was keen to come off that medication. So we did a care plan. We identified her early warning signs, which were the development of hallucinations, but also poor sleep was a massive trigger for her. And we came up with a plan to reduce that medication over 3 months, and she successfully came off it. She was on sertraline as well, which she also wanted to come off, but we agreed to have a kind of slightly prolonged period on that because she had some changes coming up at work which could potentially re-trigger things. But yeah, on follow-up, no psychotic symptoms evidence, and she was able to come off that after about 3 months. So we handed back to the GP with the care plan, included in the care plan to have some short-term Zopiclone if she did have trouble sleeping. So I guess the second most common query we get asked is about raised prolactin. All antipsychotics can cause hyperprolactinemia, and I think getting those results back as well into primary care can sometimes be a bit anxiety-provoking when the level is high. Again, there are some antipsychotics more likely to cause it than others, so particularly risperidone, paliperidone, first-generation antipsychotics, whereas aripiprazole is generally prolactin-sparing. In terms of side effects that we may see, galactorrhea, gynecomastia, amenorrhea, and sexual side effects as well. So they're ones that might be of clinical significance, and particularly for women under 25, where the bones aren't fully developed, there's a higher risk of osteoporosis. I'm going to skip over that one because I think we've not got much time left. But yeah, that's a kind of a patient journey again. It was thinking about reducing the risperidone because of side effects, and he didn't completely come off that risperidone, but it was finding that balance between him being able to do work with the Hearing Voices network, still having some symptoms, but reducing his medication. That's some advice which I'll leave you to read about the management of hyperprolactinemia. We don't have any official guidance in Sheffield, but it's thinking about, are they symptomatic? Are they asymptomatic? If it's over about 2,500, some guidance will say 3,000, think about a referral to endocrinology, and we can either reduce the dose because it is dose related, switch to something else that's less likely to cause the side effect, or potentially add something in if they absolutely need to stay on that medication. That's everything from me. Not too far.